Picture this. You notice something off. Maybe it burns when you pee. Maybe there's a discharge situation happening that was absolutely not there yesterday. You Google it, which, by the way, I'm begging you not to do at 11 p.m., and you convince yourself it's probably fine. It is not fine. You go to the doctor, you get a shot. Problem solved, right? Except 5 days later, it's not better. It's still there. That is the moment your doctor gets a very specific look on their face. Today, we're going to talk about gonorrhea, specifically the kind that laughs at antibiotics. And I promise you, by the end of this video, you will understand exactly why this matters, what it actually feels like to live through it, and what you should do if it ever happens to you or someone you care about. Quick note before we dive in, I'm an emergency physician, and this channel is all about translating what I see in the ER every day into plain English. No jargon, just the stuff you actually need to know. If that sounds useful, hit subscribe. Let's get into it. Okay, real quick. What is gonorrhea and why does it get its own scary documentary treatment? Gonorrhea is a bacterial infection, one of the most common STIs in the world. And unlike what most people picture, it does not stay politely in one spot. It can affect the genitals, the throat, the rectum, and in some serious cases, it can get into your bloodstream and start attacking your joints. Your joints. As in, you could have a knee infection from an STI. Medicine is wild. Now, here's the part that trips most people up. You can have gonorrhea and feel completely fine. No symptoms, no clues, nothing. The CDC estimates that a huge chunk of infections, especially throat infections, produce zero symptoms. So meet Alex. Alex had a sore throat that didn't quite go away. Figured it was allergies, a little fatigue. Thought maybe it was stress. It wasn't until a partner reached out saying, "Hey, I just tested positive for gonorrhea," that Alex got tested and discovered the throat swab was positive. Alex had been unknowingly spreading a throat infection for weeks with zero symptoms. That is why this infection is so hard to control and why screening, not just symptom checking, is so important. When symptoms do show up, here's what they actually feel like. Burning when you pee, not a mild discomfort, more of a, that really hurts. Discharge that is a color it shouldn't be. Yellow or green are the main offenders. Bleeding before periods or pelvic pressure that feels vaguely wrong. Rectal pain or discharge if there was anal exposure. Or, like Alex, a sore throat that just doesn't quit. The point is, symptoms vary wildly, and sometimes they don't exist at all. Here's where things get genuinely fascinating, and honestly, a little terrifying. Gonorrhea has been destroying antibiotics like a video game boss clearing through power-ups. 1940s, penicillin was the miracle cure, until gonorrhea evolved past it. 1980s, tetracyclines, same story. 1990s, ciprofloxacin, seemed like the answer. By 2007, the CDC had to pull it as a recommendation because resistance had spread worldwide. And now, we are down to one first-line treatment, one injection. That's it. Now, important clarification because I don't want you panicking in the comments. Drug resistance does not mean untreatable right now. In the US, the single remaining treatment, a ceftriaxone injection, still works for the overwhelming majority of cases. The problem is we're basically out of backup options. Here's a good way to think about it. Imagine you're playing a game and you've used up every extra life. You're not done yet, but you're playing with zero margin for error. That's where we are with gonorrhea. And the reason the bacteria keeps winning? It's almost unfairly good at evolving. Not only does it mutate quickly, it can steal resistance genes from neighboring bacteria it encounters in places like the throat, which is part of why a seemingly harmless sore throat matters a lot more than people realize. Every time someone takes an antibiotic incorrectly, wrong dose, not finishing the course, using leftover pills from a friend, The weakest bacteria die, and the strongest ones survive. Rinse and repeat. That's how you build a superbug. All right, let's talk about what actually happens when you go to a doctor, because the experience itself can feel intimidating if you don't know what's coming. So let's meet Jordan. Jordan had burning when urinating and felt vaguely awful. Waited 2 days. Googled extensively. Made every symptom worse in her head. Finally, called a clinic. The nurse asked Jordan a series of questions that felt, in Jordan's words, extremely personal for 9 a.m. on a Tuesday. Things like, which types of sexual contact did you have? Genital, oral, rectal. Have you taken any antibiotics recently? Even ones left over from a past prescription. Has a recent partner been tested? Have you traveled outside of the country? Jordan answered, slightly mortified. Here's what I want you to know. Those questions are not judgment. They are math. The answers determine exactly which tests to run and exactly which treatment to give. The more honest your answers, the better your treatment. That's the whole equation. Now, testing. This is where a lot of people get shortchanged without even knowing it. If you only had genital contact, a urine test is fine. But if there was oral or anal exposure, you need throat swabs and rectal swabs too. A urine test will completely miss infections at those sites. Jordan, as it turned out, had a genital infection that the urine test caught, plus a throat infection that would have been invisible without the swab. The treatment? A single injection of ceftriaxone. For most people, that's it. One shot, often given with pills to cover co-infection with chlamydia, some follow-up care, tell your partners, and done. Most gonorrhea infections are uncomfortable but straightforward. Treated promptly, they heal. But untreated or undertreated, things can get genuinely serious. And I want you to know what those signs look like. Meet Jen. Jen noticed symptoms but figured it would resolve on its own. Waited 3 weeks. By the time Jen went to the doctor, the infection had traveled further, causing pelvic inflammatory disease, or PID. Jen ended up in the hospital with severe pelvic pain and fever, and came out on the other side with some long-term complications that affect fertility. I'm not telling Jen's story to scare you. I'm telling it because 3 weeks earlier, one injection would have fixed it. Okay, back to our original scenario. Someone got the shot, days later, still symptomatic. What's happening? Here's the most likely explanation, and it's not what most people assume. It's almost certainly not antibiotic resistance. The most common culprit? Reinfection. A partner wasn't treated, contact happened before the waiting period was up, or there was a new exposure. This is, by a wide margin, the most common reason treatment seems to fail. Second possibility? It was a different infection all along. Chlamydia, a yeast infection, something else entirely, and the gonorrhea treatment didn't touch it because it wasn't what you actually had. Third possibility, the body just needs time. Bacteria dying doesn't mean inflammation disappears overnight. True antibiotic resistance? Rare, but real and growing. The warning signs that suggest it might be resistance are symptoms that don't budge after 3 to 5 days with confirmed no new exposure, a follow-up test that comes back positive, recent travel to regions where resistant strains are more common, a partner confirmed to have drug-resistant gonorrhea. If that's the situation, your doctor will order cultures, actual lab-grown bacteria that gets tested against different antibiotics to find out what still kills it. Infectious disease specialists will get involved, and the case will get reported to public health authorities, not to get you in trouble, but because tracking resistant cases is how we stay ahead of a potential outbreak. The key action item on your end: finish your treatment, wait 7 days before sexual contact, make sure your partners get tested, and retest 3 months later. Reinfection is extremely common and entirely preventable. Here's the big picture. Gonorrhea is not some rare niche problem. It's one of the most common bacterial infections on the planet. It's increasingly resistant to antibiotics, and we are down to one working treatment. We are one bad mutation away from an infection that is genuinely difficult to treat. But here's the thing, individual choices add up. The way this doesn't become a crisis is a million people making the boring, responsible calls. Use barrier methods. Condoms dramatically reduce transmission. Get screened regularly, even with no symptoms. And make sure you're tested at every exposed site, not just a urine test. When you get treated, take the whole treatment and make sure your partners get treated too. Don't use leftover antibiotics. I cannot stress this enough. If symptoms persist after treatment, go back. Don't wait. There are new antibiotics in development and surveillance programs actively monitoring resistance worldwide. But protecting the treatments that still work, that's on all of us. If this video helped, hit subscribe, because this is what we do here. Break down the scary medical stuff so it feels less scary and more manageable. And as always, stay prepared, not scared.